So remember, way back when, 3 decades ago when I started in the field of cornea, only a couple things to do for keratoconus, either a contact lens, a rigid lens, or a corneal transplant. Nowadays, there are many interventions that can help you in a variety of different ways. In KC, there are 4 general therapeutic goals. We can follow the road to getting better vision with glasses and contact lenses. We have a variety of procedures now that can surgically enhance and reconstruct the corneal optics. Transplant procedures, obviously. And now we have an ability, potentially, to stop progression of keratoconus. Now, you recollect, keratoconus is inherently a biomechanical problem. The cornea is structurally weak and thin with progressive deformation, leading to irregular optics, leading to visual static and poor visual function. So let's step back again to corneal structure. If we look at the building blocks of the corneal lamellae, we see collagen. Collagen is a triple helical molecule that winds on itself, linked together by intramolecular hydrogen bonds. Each of these collagen molecules is then linked together by crosslinks. These crosslinks link them together to form a collagen fibril, which are the basic fibers, the basic supporting struts of the cornea. These then, as we saw, come together to form the collagen pancakes, which form the superstructure of the cornea. Now, the lack of biomechanical strength in keratoconus suggests if we are able to strengthen the cornea, can we decrease the progression of keratoconus, and hence the development of corneal collagen crosslinking. Crosslinking has been studied nearly for 2 decades now. It was originally devised in the laboratory of researchers in Dresden, Germany, who first described the process of strengthening the cornea via crosslinking. Crosslinking takes advantage of 2 fundamental processes. First, ultraviolet radiation in and of itself will tend to form crosslinks within collagen. This is the reason that if you sun a lot, that your skin becomes more wrinkled as you get older than if you've avoided the sun. Crosslinking is the reason that your knee becomes stiffer as you get older, because the collagen that makes up the tendons and ligaments of your knee becomes cross-linked and stiffer as you get older. But cross-linking from ultraviolet light alone takes a long time. To get a substantial amount of cross-link will take literally hundreds of years. Hence riboflavin. Riboflavin is vitamin B2. Riboflavin is a large yellow molecule that acts as a photosensitizing agent. Riboflavin absorbs ultraviolet light at 2 peaks, 366 and 445 nanometers. So this is the ultraviolet spectrum, which is near the blue spectrum of light. Thus, when you add the 2 together, you potentiate collagen crosslinking. The interaction of the ultraviolet light with the riboflavin produces 2 things. It activates the riboflavin into a high energy state and also produces what are called reactive oxygen species. So when these interact with the corneal collagen, they cause the formation of additional crosslinks within the collagen of the cornea. These crosslinks may be within the collagen fibrils, they may be between the fibers, or they may be between the collagen and the proteoglycan syrup sugar matrix of the cornea. Suffice it to say, though, linkages are formed in order to make the collagen stronger. It's analogous to putting extra wires on the suspension bridge that we saw to make that bridge stiffer and stronger. And indeed, this is what happens. This is from the laboratory in Dresden. You can see beforehand this is a slice of cornea, and afterwards you can see that the cornea is stronger and stiffer. Now, how is the procedure done? You remember when we looked at the anatomy of the cornea that there are surface cells. For the traditional collagen cross-linking procedure, those surface epithelial cells are first removed in order to allow better penetration of the riboflavin drops, which are these syrupy yellow drops. Drops are then administered every 2 minutes for 30 minutes. At the end of the 30 minutes, we look at the cornea through the slit lamp microscope, and what we see is uptake of the yellow riboflavin into the cornea. Here in cross-section, you can see that the cornea is green throughout. Once you're satisfied that there's plenty of riboflavin in the cornea, you will then look up at an ultraviolet light source. Again, this light source activates the riboflavin and sets the cross-linking process in motion. Again, with the treatment that has been done for the most part to date, it's a 30-minute exposure of the ultraviolet light. At the end of the procedure, a bandaged soft contact lens is placed. This is a therapeutic contact that has no power. The goal of it is to promote healing and to make you more comfortable. This is left in place for usually around 5 days, which is the amount of time that the healing process of the epithelial cells takes for conclusion. You'll receive an antibiotic and anti-inflammatory drop for a week or two afterwards. So, what are the results? These are included in the study that we did in your packet, but to review them here, what we're going to look at are two studies. One is the large prospective randomized clinical trial, which was done amongst 10 study sites, 205 patients who had progressive keratoconus, 175 who had keratoconus after ectasia, and also our group that we studied in our center of 85 cross-linking associated eyes. So first, let's look at the optical outcomes. Remember, the primary goal of collagen cross-linking is to keep the cornea from getting worse. It is not to change your vision. And the way we first analyze this is we look at the cornea over time and look at the corneal topography. Here we look at the high spot of the corneal topography, and we're trying to ask the question, is that high spot getting higher? Is the keratoconus continuing worsening? Is the high spot stable, or is the high spot better? In this study, we randomized people who came in. So you would either receive the cross-linking or you would be in the control placebo group, essentially not get treatment. So I just turn your attention here to the keratoconus group. Down is good, up is bad. Down means you got better. So in the keratoconus group, out of the 205 people who participated, people who received the collagen cross-linking were stable and indeed on average got better. And they got better by 1.6 diopters. So the steepness decreased on average a little bit. This is compared to the control group who did not get cross-linking. And what you see here, as expected, without treatment over time, and this is over a 1-year period, patients tended to get worse. So in general, looking over a 1-year time course, treated patients remain stable, even get a little bit better. Non-treated patients get a little bit worse. That is, they continued to progress. So here the results look good. It looks like the cross-linking is doing something to render the cornea more stable. Now if we look at this a little more critically, if we look at individual eyes, we find that most people from the point of view of progression remain the same. 31% actually got a little better. So 31% improved by 2 diopters or more. So there was a substantial actual improvement of the corneal topography. 3.5% continued to get worse. So these are the patients who, despite getting cross-linking, continued to progress. Now, if you do get cross-linking, there is a clinical time course to the effect. And what you find here are patients before treatment. 1 month after treatment, because of the wound healing process, you actually get a little bit worse. And as the healing continues, there is continued improvement with stabilization at 6 months and continued stabilization over the next year. So you improve over time. If we look at these corneal topography maps, we studied these and we found that on average, patients' corneal topography either remained stable or improved with cross-linking. So here's an example of a patient preoperatively. You see a high spot of 64 in this red area. And postoperatively, you can see the cone has diminished and the high spot here has decreased to 59. So looking at various specific indices of corneal topography, we see that a number of them actually get a little better. If we then look at visual static, at higher order aberrations, similarly we see improvement. We see improvement generally in vision static and specifically in what we call coma, which is the up-down doubling or comet-shaped appearance that you may see. So in general, the optics, what we're most concerned with after cross-linking, appear to remain stable and indeed on average improve in a number of people, but do get worse in some people. Now let's look at actual vision outcomes. How do you see afterwards? First, looking at uncorrected vision. On average, there is a slight improvement in uncorrected vision 1 year after cross-linking. Preoperatively, patients were 2137 to start and 2117 to end. So not something that's that noticeable from your point of view without glasses, but clearly something that's encouraging. Again, you're going to see a little worsening at 1 month because of the healing process, and then improvement thereafter. Again, if we look at this from an individual patient point of view, most patients' vision remains stable. Around 32% actually improve by some substantial extent. So about 1/3 of people are going to say, hey, my vision is a little bit better afterwards. About 12% from the point of view of uncorrected, without glasses vision, about 12% get a little worse. More importantly, looking at glasses-corrected vision, on average, again, patients improve by about 1 line, here from 2045 to 2034. Again, you see a typical wound healing time course where you get a little bit worse at 1 month and improve thereafter. When we look at individual people, again, most remain stable. 22% get meaningfully better. And again, 3.5% get a little bit worse. And with regard to vision, we also looked at subjective vision. That is, hey, as a patient, how do you think you're seeing afterwards? We looked at questionnaires preoperatively and postoperatively and found here that a number of visual function criteria were improved. Night driving, glare, halo, starburst, all on average got a little bit better after cross-linking. Now, as I said, there is a healing time course where you're going to get a little bit worse. And the reason for this is that the surface cells need to heal over. And also after cross-linking, you're going to notice a little bit of haziness of your vision. When we look at the cornea right afterwards, you see a little granularity, a little dusting of the cornea. And afterwards, what we call a demarcation line, or a little bit of haziness as one might have on a windshield on a rainy day. You can see this in cross-section. Here's the front of the cornea and back of the cornea, clear initially. These white areas are a little bit of that hazy granularity, and that remains for about 3 months and then clears afterwards. So as a patient, you might notice that the vision is a little hazy over the first 3 months of the process after cross-linking. Now we saw that some patients got better and a few patients got a little worse. So we wanted to look at, are there any characteristics that we can identify when you come in to say you're a good candidate or not a good candidate for cross-linking? So we looked at, again, these eyes in the study, and we analyzed characteristics such as gender, age, what group you fell into, how big your cone was, visual acuity, thickness of the cornea, and we looked at the two outcomes. We looked at the optical outcomes, that is, has your corneal topography changed for the better or worse, and has your glasses corrected vision changed for the better or worse. So first let's look at predictors of the corneal topography getting better. Here we saw again that about 30% of patients indeed got substantially better, 3.5% got a little bit worse. And what we found in general was that people with worse keratoconus had a greater likelihood of actually improving afterwards. That is, if your cone steepness was 55 or more, you were 2.7 times more likely to improve that cone by 2 diopters or more. So this is just a predictor of getting better. It's not a predictor of stability. Everybody remained equally stable, but patients with worse KC on average tended to get a little better. Next we looked at glasses corrected vision. Again, most people remained stable. On average, people gained 1 line on the visual acuity chart. About 22% got better, about 3.5% got worse. Well, these 3.5% were only 3 eyes, and they lost 2 lines of glasses-corrected vision. There was no real reason we could see for that. If we looked at those factors that predicted that you would get better, we found that patients who had vision of 20/40 or worse with glasses had a 4.5 times greater likelihood of improving their vision by 2 or more lines. The flip side of the coin, we found that patients who were 20/30 or better had a slightly greater risk of losing 1 line of vision afterwards. So if you were 20/20 to start, you had a slightly greater risk of ending up 20/25 than if you had worse vision beforehand. So taking this all together gives us a treatment tree. It gives us a suggested criteria for treating or not treating a patient with keratoconus with collagen cross-linking based on, is their disease progressing? How is their vision to start with? How bad is their keratoconus to start with? Now there's some new trends in collagen cross-linking. And the first is what we call the KXL procedure, or accelerated cross-linking. This is a new unit that operates at a higher ultraviolet light power. This is something that has recently entered clinical trials. We started it 3 months ago and are treating patients now and undergoing data analysis. The standard cross-linking procedure that we just discussed has a unit that operates at 3 milliwatts for the engineers here, and we use it for 30 minutes. The current treatment in this clinical trial uses a light that operates at 30 milliwatts, and the treatment's only for 4 minutes. The procedure is otherwise the same. It's currently in clinical trials, and in this clinical trial there is a placebo group. So one eye is treated, the other eye receives a placebo, and patients who are in the placebo group are then treated 6 months after. Another area of interest in collagen cross-linking is the possible use of what's called transepithelial or epi-on cross-linking. Transepithelial cross-linking is the same cross-linking procedure, but without removing the corneal epithelial cells. Now, to date, this has been difficult because past studies suggested that you needed to remove the surface cells in order to allow the riboflavin to absorb into the cornea. However, investigation of new drugs and delivery systems have suggested ways that we are able to facilitate proper absorption of the riboflavin into the cornea with successful treatment. This is a clinical trial that we are currently undertaking as well. Now, what are the advantages and disadvantages theoretically of transepithelial cross-linking? The advantage is that the cells aren't removed, so recovery is faster, discomfort is less, and there's less potential of corneal infection. The disadvantage really is in the possibility of its efficacy not being as great. Because the epithelium is in place, there may be decreased riboflavin absorption. The epithelium itself, because it has some thickness, may absorb some of the ultraviolet light and decrease the depth of the cross-linking. In the future, however, this may be enhanced by different ultraviolet sources and different riboflavin formulations. Here are some early results from our clinical trial of transepithelial epion cross-linking. Only a small number of patients that you see here analyzed. We found that indeed most patients were stabilized and improved, but this is only over a 3-month time period, improved by 0.9 diopters. On average, an improvement of almost one line of visual acuity uncorrected, and or half a line of visual acuity with glasses. So this is an ongoing study, and I'm sure that next year we'll have a lot more in the way of results and comparisons for you. The future of cross-linking is also in combined procedures: Intax, PRK, CK, Caraflex, LASIK, and these are things we'll discuss a little bit later. Remember again, cross-linking is under clinical trials in the U.S. It's not FDA approved in the U.S., and all treatments need to be done under sanctioned, approved clinical trial protocols. We have a number of protocols that we are sponsoring. Cross-linking simply for keratoconus and corneal ectasia, transepithelial cross-linking, cross-linking and Intax, and Caraflex and cross-linking, which we'll discuss in a little bit, and as well the Avedro-sponsored clinical trial of accelerated cross-linking, which are all available now.